Any questions before we get started?
Sorry, number 13.
Yes, ma'am. There might be a few times I have to take a phone call today. I've got several meetings this week and I've got to get some numbers to them, so if I can stop, I apologize in advance. All right. The respiratory system has 5 basic functions. Number 1 is obviously, well, they all kind of go hand in hand. Gas exchange is going to be the biggest one. Gas exchange occurs where? The alveoli. Protects respiratory surfaces from temperature changes, invading pathogens. Where does our respiratory system start? Nose or mouth. Obviously provides sounds for communication, which I'm doing right now. And provides olfactory sensations to the nerve. The major anatomical structures are your nose, your pharynx, your larynx, trachea, bronchi, lungs, and I would even add for our purpose, especially from here on out, the alveoli, which I understand is part of the lungs, but differentiating them, in my opinion, is important in understanding exactly what they do. When you're looking at the anatomy, please understand you have nasal pharynx. So how it's listed here, you actually have 2. Looking at your trachea and your bronchus and your bronchi here, notice how they split, and one of them is a more deviated separation. That's why if you ever heard the term right main during intubation, whether you've been with a partner or not, that is able to perform that. You can see there's a lot smoother transition going to this right side than there is this left. So if you take a tube too deep, it's just typically going to be right main, because it is very difficult. It can be done, but it's very difficult to go left main just because of how hard and abrupt that angle is. The right side is more a continuum from your trachea, while your left one just branches off. Your lungs contain your bronchioles and your alveoli. Your bronchioles are like the arterioles of your arteries. Your bronchioles are like that of your bronchi or your bronchus. They do the same thing, they're just smaller in stature. They're a Hey! How much fuel is left in that tank? You know? I'll look later. They contain cartilage rings that provide structure. Unlike your esophagus, your trachea and your bronchi have cartilage rings to keep them open, because if they didn't, they would continually collapse and it'd be very difficult to breathe. The tissue is the same, but they have cartilage in there to provide structure and keep them open. Your respiratory tract is divided into 2 divisions, conducting and respiratory. The conducting portion begins at the entrance of the nasal cavity. It includes the pharynx, larynx, trachea, and bronchi, and ends at the larger bronchioles. It delivers air to the lungs. It helps filter, it warms, and also humidifies the air that we breathe in. It helps protect the alveoli from debris, pathogens, and things in the environment. That's why for firefighters, after you go into a fire and you blow your nose, you got all that black soot that comes out of your nose. That's your nose trying to help filter that. The hairs in your nose try to cling on to everything it can that it realizes we're not supposed to be breathing this in. The respiratory portion starts at the smaller bronchioles and also includes the alveoli. The nose is the main entrance, or one of the entrances, paired with external, obviously, nostrils, or nares, and it opens into the nasal cavity in the back of the mouth. Your nasal cavity starts pretty much where it goes flush with your face and contains all the way where it dumps back into your throat. You have a nasal vestibule. Contains flexible tissue, contains your hairs, and it helps guard the nostrils and your respiratory system from airborne particles. What is the vestibule on the building? Hallway. Little entrance, right? Your nose here is the vestibule to your respiratory tract. It's the little part that sticks out front, just like we've got a vestibule up front, same concept. You have lateral and superior walls. They're comprised of the maxillary, sinal, frontal, ethmoid, and sphenoid bones.
County EMS, code 3, active senior 32-year-old female, 358 South Oak Street, 358 South Oak Street.
Your nasal septum contains hyaline cartilage. And it's separated into your left and right sides.
County EMS, code 3, active senior 32-year-old female, Paramedic connection. 358 South Oak Street, 358 South Oak, just north of York.
The nasal cavity has a floor which butts up to where? What does that floor separate? Huh?
Roof of your mouth.
Your mouth and your nose. Your nasal floor is also the roof of your mouth. Palatine and maxillary bones forms a hard palate.
That's pretty clear.
So if we stick our tongue to the roof of our mouth, we're also touching the floor plate of our nasal cavity. Nasopharynx is separated from the nasal cavity by internal nares. You have a soft palate that extends behind the hard palate, which is back here. Towards the back of your throat where it starts to make an angle, that's typically where the separation between the hard palate and the soft palate begin. Which that is on page 577 for reference. Sorry, 579, but that was a 6. 579. My apologies. The nasal concave projects towards the septum from the walls of the nasal cavity.
Patient, with breathing, aspirating, understanding the collar.
Escalating quickly.
She gives a shit magnet. Every call I've made with her has.
Send another truck. Yeah, somebody, instead of being on our phone, if we can send the other truck, that'd be great. It helps promote filtration as air flows between them. Again, it's like a ribbed wall on each side. And they help create turbulent airflow, which allows time for it to be humidified and warmed within the body. Your respiratory system contains mucosa that lines the nasal cavity and much of the respiratory tract. It's composed of respiratory epithelium, which would be what? Internal skin. It's respiratory, the way that they're stratified is specific to your respiratory tract, and it's continually covered in mucus, or should be. Surfactant at least. Ciliated columnar epithelium is what is that respiratory epithelium is structured as. It contains goblet cells. Your lamina propria is the underlying loose connective tissue and also contains those mucus glands. Mucus is produced by the goblet cells and the mucus glands. Help coat the surface of the nasal cavity and the lower respiratory tract. That mucus assists in trapping debris and microorganisms that we breathe in. Much like your digestive system, they're moved by cilia. They're moved to the pharynx to be swallowed. Or you do those big hawks and spit it out. Your nasal cavity is flushed by that mucus. That mucus is produced in the paranasal sinuses. The sinuses are obviously comprised of the frontal sphenoid, ethmoid, and maxillary bones. They're also flushed by tears
Tag 3, Medic 1, I'll be on standby. CPR is in progress.
Flushed by tears through the nasal crimal duct.
Clear on Medic 1, clear.
Okay, 6 days on. Your pharynx contains your throat, shared by the digestive and respiratory systems. Not only does the air move, but liquids and solids do as well. Begins at the internal nares and extends to the esophagus and the larynx.
Tag 3.
Your pharynx is divided into 3 divisions: nasal, oro, and laryngeal. Your naso connects the nasal cavity at the internal nares, as we discussed earlier. It extends to the posterior edge of the soft palate.
Got that should show Medic 1 on CPR 3.
Contains the pharyngeal tonsil and entrance to the auditory tubes.
The tonsils actually serve a purpose as well.
Yeah, they're kind of a lymph structure that help absorb and secrete things. Mainly they're a nuisance nowadays, though, especially between tonsil stones and inflammation and tonsillitis and all of that. That's why you can obviously live without them. Your oropharynx extends from the soft palate and continues to the base of the tongue. You can see the hyoid bone. What's unique about that?
It's floating, suspended.
Correct. It's not connected to any other bone. It's just floating in your throat. It contains the palatine tonsils and are lined with stratified squamous epithelium. Geopharynx extends from the level of the hyoid bone to the entrance of the esophagus, and obviously the trachea is in there just above the entrance of the esophagus. It is lined with the same epithelium that your mouth is.
Do you also do absorption in that area? Is that why there's the stratified squamous?
I can't understand you up.
So did you also do absorption in this area? Is that why there's the stratified squamous? Or
Yeah.
is it just for
It's for structure
structure?
and elasticity. This is yesterday's, couple days.
Everything that I gave you yesterday is a logo what that I have since the order.
It's gonna be figure out where you're going to do. And if you could ask Shania, what's her name? Who does this?
Chestnut.
Yeah, if she can make sure that gets put into the list. At least the big one, the 203,000. You did put the new phone number on the paramedic one, right?
Yeah, I've already started on that.
Okay. The larynx is also referred to as your voice box that begins at the glottis. Consists of 9 separate pieces of cartilage, stabilized by ligaments or muscles. We'll learn as we go on. They're more predominant in most males, but your Adam's apple is actually part of your thyroid cartilage, and that is the landmark that we use for surgical crikes or needle crikes. Typically you have to hyperextend their neck a little bit. You can find where it's at, and you'll feel a small valley in between another ring of cartilage, which is your cricoid cartilage. And that's where we apply crike pressure or do the Selleck maneuver right here. And that is actually where we'll go if we do a crike. I will tell you, if you ever have to do that, it is not a fun experience. Way more blood than you'd expect. And very fragile structures in and around that area. You have to be careful because while you may be successful in saving their life, they may be on mute the rest of their life though as well, because you can obviously damage their voice box to where it no longer works and then they talk with a mute button on the rest of their life. Your larynx contains 3 cartilages, epiglottis, thyroid, and cricoid. Those are all landmarks that we use for intubation. Again, if you're going to, at some point in this class, you will not only assist with innovations, but you'll be doing them yourself as well. And if you ever ask for crike pressure or Selleck, that's what you'll be doing, is you'll be taking 2 to 3 fingers. You can either use these 2 or you can use like a combination of 2 on this side. You'll find where that thyroid and that cricoid meet, and you'll simply just gently push up and down a little bit. And what that's doing, it's moving the muscle that's connected to your epiglottis that helps fan that out, and it's setting down that sight picture during intubation so it's not as anterior, meaning it's not as far away. So we're pushing it back down into a more centralized location of the throat, so when they're in there with the sight picture, it's dropping that down so you can get a better visualization. Your epiglottis is a shoehorn-shaped cartilage that protects the glottis, or above the glottis. It folds over the glottis during swallowing so we don't do what? Or aspirate, correct. When we do that whole prong pipe maneuver, when we try to drink or eat something, that's because your epiglottis partially failed to do its job. It doesn't mean you fully aspirated, it just means they got real close and it did not like that. And that's why you start coughing and hacking for 3 minutes straight, because your body wants to make sure that nothing got in there. Now, obviously, we'll learn as we go on. If for some reason, like they're dealing with right now, someone starts to aspirate or is choking, and we're trying to do an intubation, and let's say we find solid within our respiratory tract, what do?
Suction it out.
Okay. What if we either A, can't suction it out because it's too deep, or we can't get it with McGill's?
Push it in.
When in doubt, push it out. They can do a bronch later. If you ever have an airway compromise where these people aren't breathing, take your bougie, force it down. Because one lung's better than no lungs. Now, not great, like if you see it in there and you can get it out, don't just back it, don't get it later. Like, get it out if you can. But yeah, it happens quite often, actually, that you'll have to force something through, and then you'll just have to get bronch, which is like a debridement of your lungs later on. But you do have to be careful because, again, whether it's our bougie, our tube, food can damage that larynx quite easily. It's very fragile structures. Your thyroid cartilage is curved, forms the anterior and lateral surfaces of the larynx. Also referred to, again, like I said earlier, as the Adam's apple. Superior to the cricoid, meaning what? Above. And protects the glottis and entrance of the trachea, obviously from the interior side, or the interior side. Provides attachment sites for your laryngeal muscles and your ligaments. Which do what? What do those laryngeal muscles and ligaments do?
Structure?
Provide structure to the top of your respiratory system, your lower respiratory system. Your cricoid cartilage provides posterior support to your larynx. It also does the same thing that your thyroid does in your thyroid cartilage in protecting the glottis and entrance to your trachea, and also helps provide attachment sites to those same muscles and ligaments. Your larynx contains 3 pairs of smaller cartilages. They're listed here. They are actually what you'll see during intubation. So there is a artistic version, and there is somewhat of a very good depiction of actually an actual real life interaction with that anatomy. Very rarely are we dealing with people's vocal cords that are that predominantly white and pearlescent almost, just because there's usually a lot of secretions, debris, or swelling going on in that area. But when you go to your OR time, your site picture should be very similar to that, with 2 very predominant pearlescent lines. Those are your vocal cords. That's what's actually doing all the vibration. Those are what we do not want to touch during intubation, because we can rip those, and then again, you're going to sound like Daffy Duck for the rest of their life if we damage those. You have a set of vocal cords called false vocal cords. They're inelastic. They're enclosed by epithelial folds that extend across the larynx. It's actually these flat plates that are next to your actual vocal cords. This site picture here, all of these, would be like if we're looking at the patient and they're somehow laying face down. So to get what it would be like if we're doing an intubation, you're either gonna have to hang upside down or flip your book for a second, and that's the site picture that we will see. When we're doing intubations, that epiglottis should be up top. And that widening opening is going to be towards the bottom. Your false vocal cords assist in reducing the size of the glottis and its opening. It prevents foreign objects from entering the glottis. They assist in protecting the more delicate pair of vocal cords that we have. Your true vocal cords are those pearlescent white ligaments or lines, if you will. They extend between the thyroid cartilage and the erythroid cartilage. Your true vocal cords are connected to small muscles that insert on the cartilage, and they help change the position and tension in those ligaments. And that's what helps with our inflection, tone, our change in tone. People, like singers, have much more dynamic control over those. Your coughing reflex is triggered in contact with food or fluid at that glottis. Your glottis will try to remain closed. Obviously, we start using every muscle in our thoracic cavity to help prevent anything from entering that opening, that glottic opening. Your diaphragm goes into play and it helps compress your lungs. It forces that glottic opening open, and then that air that's quickly coming out helps expel any material that is at the entrance of that glottis. For sound production, air passes through the glottis and vibrates against the vocal cords. That vibration is what produces the sound waves that we expel out. The pitch of sound is dependent on the diameter, length, and tension against the vocal cords. Shorter cords produce a higher pitch. The diameter of the opening and the length are directly related to the larynx size. And tension is controlled by skeletal muscles and changes in position of your cartilage that help control the structures of your glottic opening. Sound of voice is amplified and resonance of the laryngeal sound. It occurs in the pharynx, oral, and nasal cavities. That's why some people sound nasally, just because more sound resonates in that nasal cavity and those paranasal sinuses, which is how their anatomy and structure works. Production of distinct words is controlled by voluntary muscles of the tongue, lips, and cheeks. So if you've ever played that game where you put that piece of plastic in your mouth that like inhibits the movement of your cheeks and mouth, you sound like a complete ner-ner. It's just because you don't no longer have voluntary control over those structures or muscles. If you've ever tried to talk while holding your tongue to like the bottom of the roof of your mouth, it's nearly impossible. Trachea is a long, flexible tube, but it is rigid. The trachea itself is roughly 10 to 13 centimeters in length, depending on your height, obviously. The diameter is about an inch.
If you end up having 30 seconds, let me know.
You guys ready for a break? It's been an hour and a half.
Where's last night?
I will start reading up there when people start. Like, go down.
Yeah, I try to put my eye on it.
I don't see no.
I don't know if you've noticed, but instead of like 20 trucks, Louisville they have like 8 trucks.
Yeah. Oh, I know.
It's fucking horrible. And it's all over that fucking contract.
Dude, we went to, first we got hit on the code 3.
No, I try to wash my faces, or I wash my faces when I time I was
40 feet, that's a haul for you guys.
So we're on the way to start bar. The note said like, cars disabled on the way. And we checked, it's been shopping, but they weren't on the run yet. So it's just us going. And I was like, oh, fuck no. I was like, go ahead and start fire. It's saying there's 3 vehicles disabled. You gotta be fucked up.
In more than one fucking spot. With that.
Yeah, fire gets over to there's 3 patients, 2 juveniles and an adult. So I'm like, hey, notes are now showing that there's 3 possible patients. We're still 20 minutes out. I don't have anybody. I'm like, oh, okay, cool. So then
Let's go fuck myself.
miraculously, a unit clears to St. Mary's and another unit clears to Udall. And we're like, can you just go over and hit the boulevard? And they're like, 251, go ahead and copy another code 3. You're about to pull up on. I'm like, okay. Seizure. Being in advance. Awesome. We get there, Philly to the scene. And they're like, yeah, he hasn't seen anything. It's probably been about 4 or 5 minutes. Awesome. Absolute takes out of fucking house.
Oh, of course. Never season it, they clean it.
Upstairs, like townhome, with the tiniest stairwell. Shit everywhere. Get there, he's seizing still. And his wife is like, oh yeah, they gave me this, like he just got out of St. Mary's procedure. They gave me this medication to give him the procedure. Didn't you put this shit in his nose? So he seizes for like 7 straight minutes.
Jesus.
And so like, once fire said he didn't see from here, I was like, is there any like ARS resource nearby? Like, you can see it. Yeah, shouldn't there's 162 in quarters.
Holy shit.
I'm like, oh, great. I'm like, I guess let's start him until somebody else clears up. So we get on the neighborhood, we get him little steps, and then 123 Adam attaches. It's a whole process of getting him out of the house downstairs. He's a big deal. Start seasoning it. This one lasts like 5 minutes. On the radio, we're just gonna go code through some minutes. You had to send 3 other units on non-emergent runs, so like, person down, I'm gonna
Yeah.
mid-pain parlay.
It was so bad tonight, we cleared a Fairfield room and put an SO water, and they told us and said just go to the doctor.
So how does that work? If people are paying your taxes and you're making calls
please explain that to us.
Cause if I lived, you're J-Town, right?
Yeah.
I'm on Bologna.
Okay, if I lived in,
J-Town.
if I lived in Oklahoma and I'm paying taxes for your fire department and you're making,
High view truck.
and you're making calls at 41st and River Park,
Yeah.
Explain that to us.
that's a
There
problem.
was a whole
People
thing,
feel away about it.
there was a whole thing, I can't remember what news, do you remember who did the mutual aid article and like news report, like chief got interviewed and shit?
I don't remember.
So it was like 2 years ago.
There's a difference in mutual aid and what you all do.
Yeah.
It's all like,
Well, and the funny thing is like, whoever, like, Louisville Metro's director of operations, whoever it is, tried blaming all the suburban services on this. And like, acting like he's sending his metro trucks out to suburban services. Like, they interviewed our chief, I think they interviewed Todd Early, I think they interviewed like a couple of other people, and they were like, no, like, we can't even service our own fucking areas because we're sending trucks to that to all day.
when I
And explain to me why they'll have 15 trucks for Derby that they don't need because the Derby has paramedics on site,
oh yeah.
but they can't staff a normal.
Well, and then this whole contract bullshit, it's been horrible the past week.
When I worked for LNPD, we would get like Anchorage all the time
Yeah.
down there.
What district?
And I worked Victory, Cali, and Park Hill. So I'd be like, I'd see an Anchorage truck, and I'm like, you boys are a long way away from home. What are you doing?
Yep.
I'm like,
Second, was that second division?
yeah.
And we had that conversation about how dispatch needs to hold every nursing home open, abnormal labs, weird bull,
They
BS.
shouldn't even
For
be.
hours.
They shouldn't even be a 911 response.
Because they're using 911 as a, oh, well, transport's gonna take 4 hours, but 911 will take 10 minutes, so let's just call 911.
They do the same thing in Jeff, it's like, no.
Well, apparently AMR is trying to get contracts with suburban ambulances to be their backups for nursing homes, and I was like, please,
Please.
you can have all the freaking Code 1 nursing home runs you can have, I don't care. Take
I don't
it.
know that AMR would be welcome back in this area.
Well, they're still doing all the transports for down there, like
Just-
from U of L.
Just U of L,
Yeah.
only U of L.
Oh, that's it?
They will not do anything else.
This whole issue started whenever they bought out Yellow Ambulance.
Yeah.
And like, this has been a foreseen issue since they took all the 911 trucks off the streets whenever they bought out Yellow.
They screwed a lot of people, but that's why, apparently. They're wanting suburbans to be like, please come back and take all our 911 nursing home runs.
Yellow was the shit back in the day.
Like, did it?
Hey, we did shit right. We had 3 medics and Jeff. We were rocking.
Look at it now.
Did you see?
Bitch, we heard Diana back
Huh?
then.
I saw
She
it.
got hurt.
No, but did you see that?
Yes, she did, she got hurt. So we had this new EMT and she was.
99-year-old woman bleeding from her nose, eyes, and mouth.
Tear ducts.
Yeah.
Kashana remembers the glory days of Yellow.
So I had her for 2 years and she was.
Those were the good days. We had 3 trucks for Jeff. We were.
Yeah, I texted.
Hey, there be days we had 3 paramedics and Jeff. Now we're lucky to have paramedics in Clark County.
I said, she's done everything but drive.
And they're usually in a Dodge Durango and no one's doing anything.
Well, McKenna didn't allow her to drive because they were in 17. And she said she wasn't allowed to drive a shift supervisor. And I was like, so I didn't know she didn't drive.
Okay, it says sign in to Vector Solutions. How the heck do you get to Vector Solutions?
She didn't know how to drive.
I remember, so I just go through my email and find.
She was close to home, and I'm 55, and then she was on 17.
I love that
She's been in.
we had this whole, like,
two different types of trucks.
Here's all this stuff to help you access it, but
Diana was bitching about calling her.
how do I get to it?
Right.
Great. Literally just got it. That and this thing called Laterosity. It's new and none of us can log into it.
I was reading all the incident reports that were on her between last night and this morning.
Oh my gosh.
Yep.
Yeah, people who live in overseas or anything.
Oh, is your
She wasn't, she was a fucking pelham. She was so pelham.
Apparently they get upset. I mean, if there's an open,
We also hired fucking
Truck.
guys with that.
you're supposed to talk to the
Yes.
supervisor. I mean, that's so odd.
That is the
But you can do the
biggest-
RT and all
She
calls
was we were
and
watching
put there.
County and then.
But yeah, I really like
her position down, I want you to.
We're using it for like
Anywhere else but
our
your
accessing our policies or SOPs
We use Lexipol for our police department and it's awful.
Yeah, she's very. The complete picture of about to put her in because Kayla's partner quit. But why don't you look at it? I went to Texas one day. Texas. Yeah.
He's still alive?
He is still alive and still working on it.
I don't trust this now.
That's gonna bite you
So,
in the ass.
this was
Yeah.
like,
Something they're gonna do is they're gonna make you sign off on every, like, to do that appropriately, they'll send out every SOD you all have, and they'll make you sign off on fucking
we're on our way to
knowledge.
Woodland.
Like, when you get hired at deputy, your first,
He said,
like,
I've
2
never
days,
heard
you're
No,
acknowledging.
it's not. When I say pond,
We have a policy besides this, when you acknowledge your policy.
so then when they got this
Sell our
change
cars,
years
he's
ago,
like,
You have to
she
acknowledge.
did a change, like, stuttered.
But the change
And
is
she was
stupid,
like,
like, it could be a verb change or a pronoun change, or, just a
I
grammar.
swear it was like 4 feet.
I was like, and Cousins was like,
Yeah, apparently they are.
He said, I didn't know what to do.
I was like, Cousins,
What does it
you're
mean?
old to be
I
around
know.
your grandpa.
I don't know, because she was 100% a stripper, but
She was a
she
stripper.
did.
We have a, like, at least I was frightened by that.
Yeah, and
Trans
that, doesn't want to work with my.
So both do.
That's fine.
Two
She just wants to work with my-
And one of them is a chronic alcoholic.
That's nice. I wonder why. I wonder why.
Like, into the, she's
For the meantime, he wants meds every time you come, he wants you to capitalize him every time you come, he wants you to do
Crestview?
IV meds, and all he does is he shoots alcohol up his chest.
I love that so much for him. I hope he overdoses and dies on it.
I'm terrible with that stuff. That's right.
Yeah.
And you're just like,
So he's ignorant too.
and like
You should tell
yesterday,
him to ask. It'll work faster. And maybe he might look up.
I'm used to working. Only once he missed it, because things were gonna get it.
Is it?
Yeah.
And so one time,
Like that.
Ellen, she's actually really
Absolutely fucking
and
disgusting.
it's important to detox center. What do you want? You want to go detox? And they're like, she's still on. We'll take it. I had meds. And you know what he got?
Nothing.
Went to the hospital. He sent home and called
She's on
911.
her, she has her own shit.
See, in Indiana, we have a law, it's called misuse of
No, Destiny,
911.
it's Destiny Garrett and.
And I will literally, like, I've literally arrested people for it.
Oh, you want a fire?
Oh, we had a freaking flyer that did that, called 911 just because he was mad at his
She said
roommate.
squad five.
And it's like, that's not
That's, that's
911.
stuff they arrest for, like,
Yeah.
when they're calling for medical, it's a really gray area, because we really can't,
Would you,
like, I can articulate it because of my medical training and experience, but like a regular officer who
Yeah.
has like CPR, they can't really, but I can stand there and be like, there was a paramedic and an EMT who spoke with this person who refused medical care, who documented that they refused medical care, and they called back and they don't want medical care again. They were warned about misuse of 911.
Yeah.
They call back again. They're going to jail where they can receive medical care.
Yeah.
so would you arrest someone who wants you to change your diaper?
No, it's not.
That's not our job.
It's not. It's not your job. But the statute says you have to be using it. Where you're right. You're right. It is. She would have. Well, then you would warn her. But like the person I arrested, they called 911 while I was standing there because they didn't like what I was doing. And I'm like, are you on the phone with 911 while 911's here? And she's like, yeah, I don't like you. I'm like, I don't like you either.
Congratulations.
Feeling mutual. Yeah.
And get wild because like they'll be like, oh, like,
Tried to do
and they're like,
yeah.
and they're like,
Hair
what?
medicine.
He says, man, like, why not?
Yeah.
It's like, I can't.
Tried to get rid of
We had a few cops,
She told,
like when I frequent flyers that would call us all the time for the same bullshit. We had a few cops just when they were off duty. I'll take you to a facility, and they drive them like 3 states over and drop them off.
Oh, wow. That's nice.
Yeah.
We need to do that with our own.
Because they would call us all the time, they just load them up in their cars after shift and drive, not every day, but they would drive far enough that they would have a hard time getting back here. And they don't care, they give them $200 and say, have a good day.
Yeah,
Fuller arrested Kenny yesterday.
he needed arrested.
He said he arrested him on Thursday and then he got back out, and then he arrested him again yesterday.
Good. Good.
Well, we had him Wednesday, he was passed out.
I hate Kenny.
I love Kenny because he's a good time. He's
I
a
hope-
good time.
I hope that he doesn't wake up.
Well, he does, unfortunately. Like when we got called to Jimmy John's the other day, Kelsey showed up, he had a whole bottle of vodka, she's like, give me your fucking vodka, she dumped it out and said, go that way to Clarksville.
I want to pour it on him and then tase him. And then... No, mind you, this is the guy that was fucking. When I say fucking, I'm literally engaging in coitus
Oh, yeah.
in the
I forgot
Walgreens
about
parking lot at 10th and Spring.
Oh, it was
Sometimes you gotta knock one out.
You do. However,
Kenny's like 70, this girl's
Ten-
like
ten-
40. Good for him.
10th and Spring is not. 10th and Spring's not the place to go.
Neither is
He
Victoria
could have
went
went to
twerking
8th
in
and
front of
Wall.
Dairy
It could have
Queen.
been private romantic.
We should
Y'all
make her-
still don't do nothing with her either.
Which is,
I
I'll make her
arrest that
our
bitch
sign.
every chance I get.
Well, she's out again, you better go get her.
I will. And
She
I
was
just,
twerking yesterday.
I don't
Say,
go
about
looking
10:30,
for
11
her.
o'clock, she'll be
Yes.
right there for the dairy.
Yes,
If I don't go looking for her, but when I see her,
you don't have to look for her, she's right there.
She'll
Well,
look for you.
she'll fight. Like,
I believe it.
she has
She's
to
fucking
fight.
nuts.
It's Chris Cantor tased her. That's the funniest thing I've ever seen in my life.
You know, a
it's
car
not
accident.
fighting, it's called a struggle snuggle.
We were on a car accident the other day that Brittany called us for.
She's the first woman I've ever ran from in my life. She was butt ass naked, and I ran out of the house.
Ugh.
She was going to struggle.
And they asked me
snuggle,
what
no
is
ass.
wrong, and I said Wimp is naked and she's trying to fight.
You weren't in little school in that situation.
All right. Trachea begins at the level of C6, and attaches to the cricoid cartilage, and ends at the level of T5. And it branches to form the right and left primary bronchi. Again, the right side is almost like a continuum of the trachea. The left is an actual branch. The trachea is supported by about 15 to 20 cartilage C-shaped rings. The open portion faces your esophagus. With it being open towards the esophagus, that helps with the back side of the trachea actually distorting or collapsing to allow the fluid to pass through the esophagus. If it was a full circumferential ring, it would be very difficult for food to pass because it would be up against a rigid wall that's not conforming to whatever you're trying to swallow. That is depicted there on the slide. The tracheal cartilage is a system protecting the airway by stiffening the tracheal walls and preventing overexpansion and collapse. That stiffening of the tracheal walls is important because, again, if our trachea was like our esophagus, it would continually collapse while we're not talking or we're not breathing, and it would be much more difficult to pass air through every time we took a breath, because that would have to expand and inflate before it could get down our bronchi into our lungs. The cartilage ends by an elastic ligament that helps adjust the diameter of the trachea. your cartilages are under autonomic control. And during sympathetic stimulation, it increases in diameter. Why?
It's a lot more air.
Because you're using some type of epi or norepi stimulation. You're going to need more air, you're going to use more oxygen, you're going to use more fuel, you're going to be doing more activity, and you're going to need to supply at a much more extensive rate. Your primary bronchi, the walls resemble the trachea with C-shaped cartilage rings and ciliated epithelium. And again, they separate into the right and left bronchi at what? Anybody know what that's called? The carina. During intubation, our goal is to stop our ET tube roughly an inch right above the top. That way, when we oxygenate, it has full disposition to bounce off that carina and go to the left and right bronchi and inflate the lungs equally. When they do a chest x-ray, especially during your ER or your, what the fuck is this place? Ambulance ride time and your clinicals, it'd be advantageous for you to stick around for them to do a chest x-ray to see where your tube placement was. That way you have a good idea about depth. When we get into this, you'll notice that each ET tube has a measurement on the side that I think they started around 18 and they go to 26. That's centimeters of depth, knowing that if your trachea is roughly 10 to 12 centimeters of depth, we've got another 6 or 8 centimeters, adjusting by this person for lip to trachea distance, then our depth should be somewhere around 20 or so on the tube. The taller the person, the more that's going to increase, just because their anatomy is a little more stretched out. We're not talking about several centimeters. We don't go from 19 to 26. If anybody's at 26, they're either 19 feet tall or you've right main them into their lungs. The right bronchi supplies the right lung. Slightly larger in diameter than the left bronchus, and it has a steeper angle of descent. This is where you'll find most foreign objects enter the trachea, or that most foreign objects that are found that do enter the trachea is at the right main stem. Your primary bronchi then extend and branch into smaller and smaller airways that form a bronchial artery. Again, you can think of your airway much like your cardiovascular system. You start with arteries, go to arterioles, go down to your aorta, arteries, arterioles, and the capillaries. Same concept is happening with your respiratory system, just in different structures. Your bronchi is going to be, your trachea is going to be here, your bronchi are going to be here, your smaller bronchi are going to be here, your bronchioles is going to continue to shrink down until you get into those alveolar sacs. Your secondary bronchi enter the lobes of each lung that branch off the primary bronchi, and they divide into 9 to 10 tertiary bronchi. It is much like a tree or tree branches, and that is why it has the term bronchial tree. Now, when I was taught, we were told to think about it as an upside down tree. The trachea is your trunk or your base of the tree, and then it branches out after that. Your tertiary bronchi branch repeatedly into smaller and smaller bronchi. That bronchi cartilage becomes smaller and smaller, and it eventually disappears at something called the terminal bronchi. It occurs when the diameter of the passageway reaches 1 millimeter. Once it becomes 1 millimeter or smaller in diameter, it becomes a bronchiole. Bronchiole diameter is adjusted and helps control resistance of airflow. It helps control the distribution of air into the lungs. During sympathetic activation, the smooth muscles of the bronchi and the lungs relax, and this causes bronchodilation. Again, the same concept we discussed earlier. During sympathetic stimulation, you need more air, everything is going to relax, bigger hose for it to flow through. During parasympathetic activation, the smooth muscles constrict, causing bronchoconstriction. In extreme cases, can become completely blocked passageways. This is often seen during asthma attacks, allergic reactions, and anaphylaxis. Bronchioles branch into terminal bronchioles at a diameter of 0.3 to 0.5 millimeters. At that point, they supply air to a specific lobule or lobe of the lung. Lobes of the lung are segmented tissue within the lung. They're bounded by connective tissue partitions. How many lobes does your right lung have?
3.
Your left?
2.
How come?
Your heart.
Correct. Lobules, there's multiple lobules within each lobe of the lung. When we get into, just like we're going to get heart, we're going to attempt to get some lung in here, and we'll show you PEEP. We'll show you how your lungs inflate or deflate with or without the presence of PEEP, how the lungs expand. It almost looks like popcorn popping up in specific areas of the lung. It's actually pretty neat.
Do you want
Huh?
if I kill a deer in November, do you want?
We'll probably be beyond that, but if you guys want to fuck with it, you can. Each terminal bronchiole divides within a lobule. They form several respiratory bronchioles. They help, again, deliver air to the gas exchange surfaces of the lung, known as what? Correct. Keep your chair for 20 minutes. At the alveoli and the ducts, you have alveolar sacs, which are connected into individual alveoli. They're located at the end of the alveolar ducts. Think of this like a bundle of grapes, right? You've got this small little stem that comes in, and then branches off into smaller stems, and then each grape has a specific stem. That's what's happening within your alveoli. Your alveoli are those grapes. Those terminal bronchioles and bronchioles are the stem, the main stem, and the feeder stems coming into those grapes. Your alveoli are where the gas exchange happens on the surface of the lungs. You have approximately 150 million alveoli in each lung. When inflated, they give a wet sponge-like appearance compared to tissue that is not, compared to the areas of the lung that are not activated or inflated. Again, it's almost like watching popcorn pop the first time that you'll ventilate the lung. Your alveolar epithelium is very thin, simple squamish epithelium. If you were to take all the alveoli out of your body, slice it open, and lay it flat, it would be roughly 140 square meters.
That's great.
Is a lot. Which is what? 420 square feet?
Like the size of the tree, but close.
That is a very small portion of the body. Within your alveoli, you have alveolar macrophages that assist with removing dust and other particles. They patrol that specific alveolar epithelium, and they help phagocytize that dust, that debris, those pathogens that might make their way down to those alveolar sacs. All over the pulp alert. Your alveoli also contain something called septal cells. They help secrete surfactant onto the alveolar surface to help combat friction, inflammation, any type of pleurisy effect, if you will. They help keep the alveoli moist, that allows them to be more elastic, because if not, you get something called atelectasis, which is the drying out and inability for those alveoli to expand. The surfactant is an oily substance. It's like a small, thin layer over the watery substance that coats the alveolar surface. Like I stated before, that helps reduce that surface tension and allows for more expansion of those alveoli. It also creates surface tension to keep them from collapsing. You have something called respiratory distress syndrome, which is a condition characterized by inadequate surfactant. This can be a result of injury or some type of genetic or environmental abnormality. People that are under this realm are the ones that you'll see taking very deep, short, forceful breaths because they feel like they can't catch their breath or breathe enough, but they have to breathe so hard because it takes more force since there's less surface tension and those alveoli collapse to open those alveoli. With that, those people become extremely exhausted. And you'll kind of see this at the end of that compensation time for your respiratory distress patients.
Is this something that CPAP can help or no?
Yes. CPAP or BiPAP or both, depending on the patient's condition, beneficial here because obviously CPAP is that continuous pressure, which is going to keep that those alveoli consistently open, with BiPAP being two different sets of pressure beyond rest and inhalation. But yes, the continuous force is going to help keep that expansion open. The problem is, once those alveoli are expanded, people start to fight those CPAP and BiPAP masks because they feel better, and now they just have this gust of air just blowing, rolling their eyes back in their head, and they try to fight it, not understanding as soon as they take that pressure off, it is going to collapse back, and they're going to just recycle into this. Kayla, get hold of you.
Yeah, I was in the ER helping them unload and get everything stored away. Zero pulling in. Yeah, she told me she had a crap ton of stuff to do this morning that could be a little bit later. Probably going to Walmart if that's what it was.
But she's got a shit ton of stuff, that's why I said she's going to need your help with it. Your respiratory membrane consists of three components: squamous, alveolar epithelium. Then you have endothelial cells that line the adjacent capillaries. And then you have a fused basement that lies between the alveoli and those epithelial tissues. So all of your vasculature that surrounds your alveoli are actually well webbed into a matrix to keep them on the surface of those alveoli. Because obviously if they weren't webbed in a matrix, they would be free floating and gas exchange would not occur how it needs to. Within that respiratory membrane in those alveoli areas, you have rapid diffusion that takes place. The distance between the alveolar air and blood is roughly 0.1 micrometers. Those alveoli receive blood from the pulmonary circuit that we know are from the pulmonary arteries that enter the lungs. Your vasculature follows your bronchial tree down the way, and so does your vagus return. An arteriole enters each lobule, and then the capillary network surrounds and starts at those terminal bronchioles. Again, your pulmonary circuit follows your cardiovascular circuit follows your pulmonary circuit. So arteries, bronchioles, or bronchi, and it keeps trending down. As your respiratory circuit gets smaller, your cardiovascular circuit gets smaller. They go hand in hand. Obviously, it would not be very beneficial to have this alveoli sac and this big ass artery running through it. It's not going to wrap around and get the surface area that it needs. Blood passes through that capillary network and enters pulmonary venules and proceeds through the vein, and it goes back to the left atrium.
You see another that's on the ring? About my head. Fine.
had a bug at 1 o'clock this morning that was like the size of a fucking bird. Right dead nuts in my line of view, and it was like packed on there. So hopefully this takes it off, because it's very inconvenient the way it works. All they're doing Washington County's working. Huh? Blood pressure in the pulmonary circuit is low. It's roughly 30 millimeters of mercury or less than your systemic circuit or your systemic blood pressure. Arteries are easily blocked by blood clots, fat, and masses just because that pressure is not there. Obviously, without forceful pressure, you know, if I stand here and I have one person pushing me, unless it's gauge, I'm going to have a very good time combating that. But if I have all of you get up and push against me, I'm not going to combat that. Same thing. That's why PEs are very prominent, especially in your older population who are already fighting hypotension issues. And people with DVTs and things like that, once they make it to their lungs, it's very difficult to combat. Pulmonary embolisms block a branch of the pulmonary artery. They stop the blood flow to groups of lobules or alveoli. They can quickly cause problems as lungs receive an entire cardiac output. So now, if some type of embolism, whether it be air, lipid, blood, saddle, whatever, is blocking, let's say, an entire lobe of my lung, what happens to the pressure in the rest of my lungs? We're not putting out any less blood, right? So now, we're dispersing that same amount of blood flow to less surface area. What's that going to cause? Huh? Pulmonary edema. And what cannot happen under those circumstances? Gas exchange. So not only do I have one part of my lung not getting any air, the other part of my lungs are now drowning themselves and cannot distribute air. And then, we'll work through it.
So why do you get the extreme color change that quick
Like
when
on
that
a code?
happens?
When they turn purple on a code?
Like during a PE during a code,
Yeah.
because what has a shorter distance from your heart? From here up or here down?
Okay.
I mean, that's all that it is. You're dealing with this much surface area, right? Versus this much surface area. And there's a lot less vasculature here. And then so in turn, if I'm having pulmonary backup or whatever, and this blood is becoming deoxygenated very quickly, you're going to see it more predominantly in this area, because this is the only part that's feeding from my superior vena cava, right? Versus this part that is feeding from my inferior vena cava. A lot more vasculature down here for the deoxygenated blood to disseminate to versus this area. And gravity, so it's going to stop here and then it's just going to fill up like a beaker. It just has to do with structural layout, surface area, and anatomy at that point. Eventually, the whole body will do that. You'll see people that if you work a code long enough, whether it's because you just feel like working a code or you're having rhythm changes that show some potential, you'll start seeing that from the nipple line down will start becoming mottled. It's the same thing happening. It's just so much more area that it's taking longer time for that to happen. There are your lobes of the lungs. Again, like we discussed a little while ago, your right lung has 3, your left lung has 2, because right here is where you have that cardiac notch and where your heart lies. Again, contrary to popular belief, your heart does not sit over here, right? It sits very middle, off to the left just a smidge. The apex, or the top of the lungs, are blunt and round that extend into the base of the neck above the first rib. Your base is concave at the bottom here because that is where your diaphragm lies in there when it is relaxed. Within your lungs, you have something called the costal surface, which curves following the inner contour of the rib cage. Your mediastinal surface are where grooves mark the passage of large blood vessels. And then you have the indentation for the pericardium, which is referred to as the cardiac notch, right here. Sorry. Pleural cavities, each lung occupies a pleural cavity inside the thoracic cavity. You have a left and a right that are separated by the mediastinum. Those areas are lined with pleura. That is a serous membrane that we discussed back 3 weeks ago. How many pleural linings do you have on each organ? Or one on the organ and then one on the outer wall or whatever it is. The visceral pleura is what?
Outside, touching the other organs.
The visceral pleura is the one that surrounds the said organ. So your visceral pleura will be the one that touches your lung, and your parietal pleura will be on the inside of your rib cage, and there's going to be a small air gap or a small space between those two. So visceral is on the organ. I just covered that, so we're going to move on. Your pleural space is the area between your visceral and parietal pleura. Those layers are in very close contact. And you have something called pleural fluid that helps reduce friction and inflammation in those areas. Again, anyone that's ever had pleurisy knows that that feels like you're getting stabbed repeatedly, and it is very excruciatingly painful, but that's because those, if we're already dealing with a millimeter or two of gap and those areas become swollen, now they're in constant contact, and then every time you breathe, it just sits there, and it's like two pieces of sandpaper rubbing against each other. It's a very unpleasant time. 10 out of 10 do not recommend. Injuries to the chest wall can allow air into that pleural space. Once that happens, we have something called what? Pneumothorax, which is also known in layman's terms as what? Collapsed lung. If that lung collapses and is not rectified, it results in atelectasis, which is a collapsing of the alveoli, and then it continues to cause that lung to shrink. If you're ever dealing with a chest x-ray for some reason, when you're in the ER, and you see something called the whitewash on an x-ray, that is one of two things, either fluid buildup or atelectasis. Atelectasis can even show very dark in color. A hemothorax is the same thing as a pneumothorax, but instead of dealing with air, we are dealing with fluid or blood within that pleural cavity. What's easier to displace, fluid or air? Air. So usually, when you only have, I won't say usually, in most cases, as long as it's not extremely trauma-induced, when you have pneumo, you can have a 10% or a 20% pneumo and it'll rectify itself, right? Because that air will displace subcutaneously and then disperse. Hemos, very rarely, if ever, will rectify themselves Because if you have blood stagnant, what happens? It clots, and then becomes stenotic, and now you have a permanent dead space of area within your thoracic cavity that does now not allow your lung to expand. This is when we'll do needle decompression. This is when we'll do a chest tube. This is when we'll have to do something to displace that blood out of there, or even a simple thoracotomy. Can anybody tell me the difference between respiration and ventilation?
Respiration is the actual change, ventilation is just pushing the air.
Correct. Respiration is the act of gas exchange, while ventilation is the mechanical moving of air in and out. Those terms are not synonymous, because can we respirize a patient? No, we can't force there to be gas exchange. We can force air into their lungs. So again, those terms are not synonymous. But within respiration involves 3 integrated steps: ventilation, gas exchange, and gas transport. Pulmonary ventilation begins with obviously breathing, whether it's them for them, you or the patient for themselves, or us doing it for them. And that involves the physical movement of air in and out of the lungs. That is known as ventilation. It's the physical movement of air. Gas exchange happens at 2 different sites: across the respiratory membrane between the alveolar spaces and alveolar capillaries, and across those capillary membranes. And that's between, obviously, the tissue itself and the vessels itself. So that not only does it have to pick up oxygen from the lungs, it has to put that waste back in the lungs for us to breathe out. Did I go over the pendulum with you guys yet? No. Okay, your heads are hurt today. Then the third step is gas transport. You have the transport of oxygen, obviously to the capillary beds and then to your heart and then to other systemic tissues. And the transport of carbon dioxide from your tissues back to your heart, through your right side of your heart, into your lungs, and then at the capillary beds, they will diffuse into the alveoli, and then when we breathe out, it pushes all that CO2 and CO out. Methane, nitrogen, all that stuff comes out. There are some abnormalities that you will experience in EMS and probably already have that are ultimately affected by gas concentrations and cellular activities. Hypoxia is low tissue oxygen concentrations. Obviously, with low oxygen concentration, that's going to limit any type of aerobic respiration or aerobic metabolism that takes place, correct?
Yes.
There can't be as much if we don't have as much. Unless I'm certain government officials, I can't spend money I don't have. Same concept for oxygen supply. Anoxia is the oxygen supply is completely cut off. There is no gas exchange. That's why if you ever hear an anoxic injury, we typically hear that, right? Especially in brains or in your noggins, is because there's been a clot that has prevented blood flow to a certain part of the tissue, and the cells quickly die because there is no gas exchange at that point. During intubation or RSI are one of the biggest places that anoxic injuries happen because of failed intubations, faulty intubations, or prolonged times during intubation. That is why it is extremely important to hyperoxygenate your patients. Here, I require all my staff to not only use passive oxygenation, but use a BVM as well, because free radical oxygen can metabolize within the body for 2 to 3 minutes afterwards. That's why with passive oxygenation of just a nasal cannula going into their nose, and then using a BVM as well, is going to help force all that free radical oxygen in. That helps limit the possibility for an anoxic injury. Now, if they take 6 minutes to intubate, they're going to have an anoxic injury and probably die, but it does help with some of the prolonged times. And once we get to that part, I know RSI is not part of the national registry curriculum, but we do teach it here because you will need to know it here for your CASTO. But when we go into that, there is nothing rapid about rapid sequence innovation. Pulmonary ventilation is the physical movement of air in and out. The respiratory cycle consists of one single inhalation and exhalation. So one in and one out is one respiratory cycle. Obviously, we should all know what respiratory rate is. If you don't, I will explain it once. That is the number of times you breathe within 60 seconds, also known as 1 minute. Alveolar ventilation is the movement of air in and out of the alveoli. This helps prevent the buildup of carbon dioxide and helps ensure that there's a continuous oxygen supply in your bloodstream to your systemic circulation and ultimately your organs. This is why PEEP is super important when we're dealing with CPAP, BiPAP, or intubation. Even BVMs. BVMs we buy here all have a PEEP valve. You have to. If you don't, you're just pissing in a fan on speed 3 and you're not making any progress. Because every time you ventilate, if you don't have PEEP, the lungs will expand very limitedly because they're almost collapsed. And then when you let go of the BVM, what happens to all that air? It pushes right back out. What PEEP is when we breathe in, it allows the lungs to expand, but then when we let out, it is a very slow withdrawal that helps keep the lungs inflated. That's why we're not continually fighting ourselves every time we bag. However, with that being said, too much PEEP is also a bad thing, because if I put my PEEP on 15 or 20 and I bag, it inflates the lungs, but nothing comes out. And if it does, it's almost just like a leaky faucet. It comes out, but not nearly at the rate that it goes in. What am I going to cause there? Barotrauma, overinflation, and limited gas exchange. Because if they don't have some ability to deflate, what's not happening? Your CO2 is not going to leave the alveoli, and the oxygen coming in has nowhere to go because it's just in this gridlock of, it's like being on the interstate and a wreck being 7 miles down the road. You can get on the shoulder of the road, you ain't fucking going nowhere though. Same concept. Air can't go in and out if there's too much PEEP. Much like your body, whether you're dealing with gradients, your lungs follow a pressure gradient. Air is obviously going to flow down the gradient much easier than it's going to flow up the gradient. Are they going home? No. Oh. Why? There. Your pressure gradient is the difference between your high and low pressures. Obviously, pressure can be changed by increasing or decreasing the amount of volume in the container, whether it's the volume in the lungs or the amount of volume we're using through BVM or a ventilator. If volume of the lung increases, pressure of air decreases. If the volume in the lungs decrease, pressure of the air increases. Because again, you have to have that movement for there to be pressure. I believe I've stated here, when you do ride time here, you will notice we only carry small adult BVMs. We do not carry large adult BVMs, and that is by design. volume of the lungs depends on the volume of the pleural cavities. Again, you have that pleural space that's between your parietal and visceral. If you have extra air in there in a pneumo, you have extra blood in there in a hemo, or you have a combination thereof in a hemo-pneumo, that is going to limit the amount of volume that is in your chest cavity for your lungs to expand. By design, the surface of each lung sticks to the inner wall of the chest. And again, if that surfactant is decreased, is how you'll get pleurisy. That's why you'll notice when you take a deep breath, your chest wall moves because it is moving with your lungs. If you let out, it'll go back in. Thoracic cavity volume and pressure is a result from movement of the diaphragm and rib cage. Again, like I just said, when you take a deep breath, your chest has to expand with it, or it is going to limit the amount of air you can intake. If someone lays on the floor and somebody else sits on their chest, it's not so much that they are crushing your chest that you can't breathe, it's that your chest wall can't expand for you to intake air. Because when your diaphragm contracts, it causes negative pressure. But in order for there to be negative pressure to cause your lungs to expand, your chest wall has to move with it.
Is that the same concept of like the higher up you are, the atmospheric pressure pushes down?
Correct. And it's the same thing if you dive, it's completely opposite. The further down you go, the more pressure there is, making it more difficult to breathe. That's why you dive, there's different classes that give you certain depths that you can go to, because after a class, I know in Florida it was a class C, which is anything below like 150 feet, like you have to go through some very invasive training, pressure training, pool training, chamber training, and all of that, just because the pressure on the human body is so much different than if you're at 50 feet. Your diaphragm forms the floor of your thoracic cavity. When it is relaxed, it's dome-shaped and projected up into your thoracic cavity and actually lays at the bottom of the lungs. When you're this is kind of asked backwards with your diaphragm and your thoracic cavity. When your diaphragm is relaxed, it's actually compressing the lungs. So when it's relaxed, it's shaped up. When it constricts, it flattens out and makes almost like a perfect line across your thoracic cavity to your abdominal cavity and allows those lungs to expand. Again, when it contracts, it flattens out, volume increases in the cavity, and that allows the lungs to expand. Obviously, all of us hopefully have a rib cage. If not, you should be in a bubble. Elevation of the rib cage increases thoracic cavity volume. Lowering of the rib cage decreases thoracic cavity volume. All that's saying is in expanding out, it's going to increase the volume, and relax, it's going to decrease it. And you'll notice to breathe out, we use those external intercostals, and when we relax, those internal intercostals take over. Before a breath or at rest, if we all sit here and don't breathe, the pressure inside our lungs and outside our lungs is the same. They have to match, otherwise what's going to happen? It's either going to expand or the lung is going to deflate. So if the pressure outside the lung is more, it's going to cause it to collapse. If the pressure inside the lung is more, it's going to cause it to stick to the wall and do whatever. So as we sit here at rest without a breath, those pressures are the same. During inhalation, the diaphragm and those external muscles contract. That causes thoracic cavity expansion. With that expansion, the lungs have the ability to fill with air. Pressure inside the lungs decrease because why? It's a negative pressure, right? If my chest wall moves, it's the same amount of air on the outside, but now more space, right? So if I took, I'm trying to put this in simple terms. If I had a 1 foot by 1 foot box, just a cube, right? And I put, I'm gonna make up an imaginary unit of measure, 10 pounds of air in it, right? There's gonna be 10 pounds of air. Think of it as literal weight, not pressure, okay? 10 pounds of air in there, or 10 liters of air in there. It's gonna be at this pressure. But if I take those 10 liters of air and put it in a 3 foot by 3 foot box, the pressure inside is not the same. Works like a barometric chamber, right? We're reducing pressure, increasing pressure. So when our chest wall starts to move and our diaphragm starts to come down, there is now less pressure against the lungs, causing them to expand. During exhalation, that rib cage moves down, the diaphragm relaxes, the volume of the lungs decrease because the pressure in the lung increases. And that air has to go somewhere and it's going to go out. Now, if you have a hole in your lung or something to that effect, it is going to go out through your mouth as well as out into your thoracic space. And that's how you'll get pneumonia. What page is that depiction on?
594.
Just in case you don't understand my explanation. Compliance is indicated by the resistance and the ability for the lungs to expand. The lower the compliance, the more effort there is required to perform a ventilation. The better the compliance, the easier it is to ventilate. I'm sure we've all bagged those patients where it feels like we've just got a BVM held against the ground and the air's got nowhere to go. Those are your lower compliance people. Whether it be because there's an increase in pressure in the thoracic space, increased pressure in the lungs that is causing them not to expand, there is some type of obstruction, whatever the case might be, we don't have the airway positioned properly, those are your lower compliance people. And then I've had those that you're bagging and there's zero resistance, you're like, am I fucking connected here? Because it's like you're just going into atmospheric space. Those are really good compliance people. You've either done a really good job or they're really broken, because the air is just free flowing into cavities that it shouldn't. Disorders affecting compliance, emphysema, which is what? Anybody know what that is? That's a form of it. Emphysema actually targets the actual alveoli. So if you don't have the ability for that gas to come in exchange, you're going to have less compliance and less elasticity of those areas. RDS, respiratory distress syndrome, is just a blanket statement for anything going on in the lungs that we don't want to give a specific diagnosis for. That's your lazy doctors. And then conditions that affect your ribs, your spinal cord, your chest wall, anything like that. Normal breathing at rest, your muscles utilized for ventilation uses about 3 to 5% of your resting energy. Again, it has to be low because if not, we would die in our sleep. When we see reduced compliance, we'll see an increase in accessory muscle use, and you'll see those patients become exhausted just focusing on breathing. Those are the patients we know we either need to CPAP or BiPAP immediately, or we know they are going to catch a tube if you have the ability to DSI or RSI. Or DAI, whatever mnemonic your company wants to use. I think there's DSI, DAI, DFI are all the same thing. Drug facilitated intubation, drug assisted.
MAI or something.
Yeah, medication assisted or medication induced, medication facilitated. Any of those where you can't paralyze, pick the other 96 mnemonics you can use for it. That means I can give Versed and fentanyl and hope to God they don't have a gag reflex. If not, we bag all the way to the hospital. That is, so if your mnemonic or acronym is not RSI, that's what it is. Fentanyl, Versed, hope there's no gag reflex. And then when you can RSI, you can do your fentanyl, your Versed, your ketamine, your etomidate, your rock, your sucks, your Beck, whatever you want to do with that to paralyze them. If you do that, you better be good at innovation. Because if not, your patient is fucked. You have modes of breathing classified with the respiratory movement. You have quiet and forced. Quiet breathing, inhalation requires muscular contraction, and the exhalation is passive. That's what most of us are doing right now, whether you're awake or asleep. Then, with those muscle contractions, diaphragm accounts for about 75% of the air movement. Your external intercostals are only about 25%. So again, it's mainly that diaphragm moving the air in and out. With forced breathing, both inhalation and exhalation are an active process. Inhalation requires accessory muscle use, and exhalation requires the internal intercostals to take place, the contraction to take place, as well as accessory and abdominal muscles to facilitate that exhalation. So if you told me to go run a mile, about 13 feet into it, I will be using forced breathing. Tidal volume is the amount of air moved in and or out of the lungs in a single respiratory cycle. Again, you will see normal is about 500. Going back to the statement that I made earlier, we only use small adult BVMs here because those are, depending on the brand, are 600 to 700. Your normal adult BVM is anywhere from 12 to 1500. Why? You need more minute volume? So let's talk about vent theory just for a second. We're going to get ahead of ourselves, but we're going to understand respiration for a second. Minute volume would be what? Anybody know? Correct, which is pretty much how do we get that, stroke volume, or cardiac output is stroke volume times heart rate, right? How would we get minute volume?
Respirations.
Correct, respirations times tidal volume. You get minute volume, right? So from a vent theory side of things, we do look at tidal volume, don't get me wrong, but our main concern is minute volume. Because minute volume is something we can, if we're having bad compliance, right, we can't force more air in or out, okay? But with low tidal volume, I can control my minute volume by what? If I have low tidal volume, right, how can I control my minute volume? Increase my respirations, right? That has nothing to do with compliance. I just say you take your shitty ass breaths more times a minute, and I can still get good minute volume, right? I can't necessarily say, I need you to breathe better, so do it, or I'm gonna force you to have better compliance. I can't control that. So, and then with that, if I have really high minute volume, because I have such good compliance, what can I do? I can either control my respiratory rate or control my tidal volume, right? So I can't force bad compliance just because I have a BVM the size of a fucking basketball and try to force all that air in. If I have bad compliance, I'm only gonna get what I'm going to get. So we can control less tidal volume with a higher respiratory rate to get our minute volume that we need. Now, in some septic situations, in most septic situations, we do want to increase our minute volume, but we have to be careful with our respiratory rate because typically with an end tidal less than 25, that is indicative of sepsis. And what happens when we what happens to our end tidal when we increase respiratory rate? It goes down. So that is the one part that we have to be careful of. Increasing respiratory rate when we're dealing with these patients is with sepsis. But in most cases, and we're going to get into it today and you're all going to be confused and we're probably going to spend an hour on it and half of you will be like, got it. And then a third of you will be like, I get it. And a third of you will be like, fuck this, I'm done. So we'll get through it, I promise, but we'll go over metabolic versus respiratory acidosis and alkalosis and all of those things and kind of understand where we're coming from with bacteria. Back to this. But again, so that's why we use those small ones, because if you need more than that 600 to 700 by BVM can supply, just increase your rate for the time being, obviously. But that gives us time to give those nebulized treatments, right? To give that MAG for for smooth muscle relaxation, to give that solumedrol, methylprednisone to help with the steroids from the inflammation. You know, that should only be a short Band-Aid to giving medication. We don't RSI and go, all right, to these, right? We're gonna sit there and continue to treat our patient with medications and stuff. Problem that we have, not every medication is immediate. Onsets, peak times, duration, all of those things can change. Onset of methylprednisone is, anywhere from 10 to 25 minutes. For some of you guys that are close to a hospital, if you give it, cool, but you're not gonna see the effects of it because you're 6 minutes in any fucking direction from a hospital. So we're here, we're 12 minutes from a station, a hospital in which is going to transfer it out, or we're 30 to 50 minutes away from where we wanna go. So that is the nice thing about rural EMS is we get to see changes in our patient condition more often than those urban services just because of time alone. But again, with those smaller BVMs, we're still going to get the required amount of oxygen that's required, or not oxygen, but ventilation that are required for sustainability. Volume can be increased, obviously, to an extent. Inhale more vigorously, exhale more completely. And again, that when we're talking about what we can control on our side, how can we control what's exhaled from what we discussed earlier? It's a Easter candy. PEEP, right? We control, by us, can control if we're doing CPAP, BiPAP, innovation, we can control how much is exhaled by PEEP. That is what PEEP is for us. Is how much pressure we're allowing to remain in those lungs, and the rest will be exhaled. So, increase of PEEP is going to allow more or less to be exhaled. Less, because there's more pressure, right? Expiratory reserve volume is the amount of air that can be voluntarily expelled at the end of a quiet respiration. So if we all just sit here and we breathe like normal a few times, and then after we're done breathing like normal, we push more air out, that is our expiratory reserve volume. That right there was my expiratory reserve volume. That is that amount that is still in there for use, but it's not being utilized. Usually about 1,000 ml. Your inspiratory reserve volume is the amount of air that can be inhaled after resting tidal volume. So again, if we all sit here and allow ourselves to breathe normally, and then we take a deep breath after we breathe normally, that is the amount of inspiratory reserve volume. That's how much your lungs aren't being utilized right now. That is the amount of space that our lungs still have for more air. And again, when we exert ourselves, we do more energy, require more oxygen, our normal resting will begin to increase because we need more at normal. In males, the average is about 3,300 ml, while females is slightly more than half of that. Vital capacity is the maximum amount of air that can be moved in and out of the respiratory system in a single cycle. So that's the deepest breath you can take and the hardest exhale force out that you can do. That is your vital capacity. I had a partner that I feel like breathed constantly off of vital capacity as much as that motherfucker huffed. One of the most unpleasant fellow that scours this earth. Residual volume is the amount of air that remains in the lungs following maximum exhalation. That's typically about 1,000 to 1,200 in everybody. That is the amount of volume that remains in your lungs so they don't become deflated and collapsed and turn into 2 chicken livers on sticks. Minimal volume is the amount of air in the respiratory system after lungs collapse. Obviously, you're going to have some air that's going to remain in those alveolar space and in that lung tissue. Like you can't, we're not wringing out a sponge here to get all the water out. There's going to be some air that's left in there. This is the amount of air that you have after a full pneumo. And when we get the lungs in here, after we ventilate them and stuff, we will stab them, and you'll see how much they'll shrink up compared to the corresponding one over there. Normal inhalation, again, is about 500, 350. About 2/3 of it is going to enter the alveolar space. Why about 150 remains in those conducting pathways. Your bronchi, your bronchioles, all of those tubes that there's not gas exchange at. That is known as the anatomic dead space because it does not engage in gas exchange. Because obviously we can't force the air in our back of our throat to our lungs just by itself. We have to take in more air to move that air down. It's just dead air is all that is. What the fuck? You can look at that on picture. What is going on? Okay. So what it's saying is you have this bottom part here is your residual. You have your normal expiratory reserve, which is going to maintain in your lungs. And you'll see your normal tidal volume is about 500. So what it's pretty much saying is at any given point, there's about 22 to 2,700 ml of air in our lungs, while we can hold 6,000. So again, I think what they're trying to probably show here is how much our body has the ability to compensate for itself with breathing. Because if we're normally only holding half, we have another half that we can sit here and still try to, whether it's carbonic acid levels, end-tidal, any of those things, our body can do through respiration. I'm not going over the first one to beat that motherfucker in the ground. Gas exchange is going to depend on partial pressures of gas involved. Diffusion of molecules between a gas and a liquid. So I don't say we all, you'll hear terms such as PaCO2 and PaO2. Those are your partial pressures of oxygen and CO2. That's how easily those gases can move back and forth and what is moving more of. Obviously, again, we have iStats on our truck here, so if Derek goes to intubate somebody and he does a iStat prior to intubation while he's setting up his rapid, non-rapid event, right? And we get a PaCO2 back of 120, what is that going to mean? Normal end tidal is what?
39.
So with the PaCO2 of that, you're gonna see about 45 to 60 is normal, right? If I'm seeing a PaCO2, which is my partial pressures of CO2 gas, of 120, what does that mean for me? That means that there is double the amount of CO2 in my bloodstream, which means that my oxygen levels are going to be what?
Whoa.
Half. Because if this is doubled, we can't just have unlimited space. So by math for me, if my partial pressures of CO2 are up by 200%, that means my partial pressures of oxygen are going to have to inversely be down by 50%, right? And that means I'm going to have to increase my respiratory rate to help with the pressure, increase my peak and tidal volumes to help exhale that. It gives us a good understanding of what our blood gases are at, so we know what the body is doing. Does that mean anything to you beyond that? No, because if you don't have a way to check it, you don't know what it is. Air is a mixture of gas, if you didn't know. About the most abundant is nitrogen at close to 80%. Oxygen accounts for about 21%. The remaining 0.5%, give or take, is just carbon dioxide, metabolites, and water vapor. Atmospheric pressure at sea level, 760 millimeters of mercury. Gas exchange contributes to the proportion of relative abundance, meaning it is going to exchange at the partial pressures in the air, and that is going to be what your body has the ability to intake. So if we go up or down, that's going to give us how much more or less those partial pressures are going to be, which is going to give us inversely how much availability or ability for us to consume there is.
So is that why when...
Don't worry about that, like, just move on from that.
So if, like, for instance, I went to Knoxville this weekend, is that why, like, my allergies, drainage issues, is that why it's foobarred now because of the elevation change?
You can have an elevation change in just the pollen content. The Ohio Valley is dog shit. It's like every bee, flower, pollinating issue that there is just somehow grows here.
I was good when I was here. When I left, when I got up in the Appalachian Mountains, I was like...
Worse?
Yes, I got like this.
Yeah. Part of that's just climate change and your exposure to the environment. Some of it can be that, the availability of oxygen, that you're consuming less, so then your histamine release is going to be more.
So it didn't really have anything to do with the elevation? It was just...
Elevation is less with that than it is your breathing efforts. Partial pressure of oxygen, again, is about 21% availability in free air. And that's about, out of that 760, about 160 of that, about 160 of that 700 is the pressure of oxygen in the air at sea level. So what I was telling you to ignore here is you take your partial pressure of nitrogen, plus your partial pressure of oxygen, plus your partial pressure of water, plus your partial pressure of CO2, and at sea level, that is going to equal 760. There's no reason to know that. It's cool, like if you want to be a nerd and you go on Jeopardy, you can know the answer to that, but beyond that, it's going to be exactly 0% useful in EMS. Rate of diffusion is going to be based off the partial pressure of each gas, and this is kind of what I was getting into earlier. Example, the partial pressure of oxygen is going to determine the rate of oxygen diffusion. back. While it does not have any effect on the diffusion rate of nitrogen or carbon dioxide, it is going to have an effect on how much there is available. Not going over that again. Dead space, air mixes with the alveolar air during exhalation. It's a mixture of both atmospheric and alveolar samples. It's just how much air is not being utilized. It's just literal dead space. Or how much area is not being utilized during gas exchange. Welcome back. How's your ear ball?
Hi, what?
Drive off.
It's fine. It looks normal. I don't know what's wrong with it.
Okay. Probably got the stink eye. Probably hotboxed you last night, you didn't know it. Diffusion of gas exchange, external respiration, diffusion of gases between blood and alveolar air, which we've talked about. Internal respiration is diffusion between blood and interstitial fluid. One occurs at a respiratory membrane, one occurs at the endothelial membranes of capillaries. Within our pulmonary artery, we have a lower PO2 and a higher PCO2 because why? It's deoxygenated blood, right? We're gonna have less volumes of oxygen compared to all the trash that is picked up from our organs and vasculature along the way. Diffusion will occur at the alveoli. When the diffusion occurs, you have that offloading of CO2, that intake of O2 that goes to the left side of our heart, diffuses to our organs in our body, and then it repeats. Pulmonary venules, oxygenated blood reaches equilibrium with alveolar air. You have a PO2 of roughly 100 and a PCO2 of roughly 40. Like I said, for us, if you do an ISTAT reading, you're 40 to 60, but you know we're on that PCO2. Interstitial fluid, your PO2 of 40 and your PCO2 of 45. And what is that very similar to? Correct, because we're breathing off what?
CO2.
And water vapor. And that is what we breathe off. Diffusion, oxygen diffuses out of the capillaries. Carbon dioxide diffuses into the capillaries. Obviously, this is that systemic circulation and continues until the partial pressures are the same as the adjacent tissues. Again, it tries to remain equal in homeostasis or maintain equilibrium. They want everything to be the same. Page what? Probably not your book. 603. Blood returns to the alveolar capillaries. External respiration replaces oxygen that is released into the tissues, and excess carbon dioxide is lost. So think of external respiration takes place at the lung, internal respiration takes place at the tissue, or the alveoli, not the lung, the alveoli. And internal takes place at the tissue. Plasma is how the gas moves and blood moves through the body. Limited solubility for oxygen and carbon dioxide. Cannot absorb enough to meet the peripheral tissues. while you will have some free radical oxygen like I referred to earlier, and some free radical CO2, it is not enough to maintain any type of status change or efficacy to tissues or organs. Red blood cells, we went over during blood. I'm not going over it again. If you'd like to go over it, please visit back. High plasma concentrations, molecules are removed by red blood cells, and with low plasma concentrations, red blood cells released, stored, reserved. Yes, sir.
Do you have does Scott County have the things on the truck where they will read the carbon monoxide on blood? What are those called? Isn't there, like, you know how you have your SpO2? Is there
Ours are integrated with our SpO2 because we use rainbow cables, so they measure methane, CO, CO2, and O2.
So the life pack will do that? Wow.
Yep. So we can read methane levels, we can read CO levels, we can read CO2, obviously oxygen.
I've only worked for Forest Services, so
I mean, it's a very good, it's nice nowadays because all of your monitors, whether you use LifePak, you use Zoll, whether it's a LifePak 15 or the new 35s, whether it's a Zoll or a Zoll X series, whether it's a Philips Tempest or whatever, they all have the ability to use rainbow cables now. Back in the day, you know, LifePak 12 and LifePak 10 days and Philips MRX days, you had to have special probes or specialized devices to read CO2 or methane or whatever. But those devices were thousands of dollars. Now, yes, I have a $60,000 monitor, but I can buy it, instead of buying a $400 SpO2 cable, I can buy an $800 rainbow cable, and by rainbow, that means it gives me the full color metric of methane, CO, CO2, in the same cable.
If something's abnormal, it will just pop up on the monitor.
Yeah, so when we set up monitors, we set up limiting thresholds. So like for ours, our limit threshold, our high limit threshold is 10 on CO. You won't see it unless you actively go in there, just go, what's my CO level? Oh, it's 2. Or it gets above 10. And then SpO2 will be flashing, and then you'll have a red flashing number that'll show whether it's the methane, the CO, or whatever it is. That's all. Oxygen transport. Oxygen content of arterial blood is about 1.5 in solution. There's no easy way to explain that I can think of, because that's dealing with labs. Not lab, well, you have to get those readings from labs. But I guess the easiest way to say that is about 1.5% of your blood is carrying oxygen, not carrying oxygen, but is actual oxygen. Is the easiest way to explain that. And that is a very awful way of explaining it, but you have to think you've got red blood cells and plasmas and all of that. But about 1.5% of that solution, that plasma blood cell mixture, is actual oxygen molecules. What carries oxygen, iron or hemi?
Hemi?
Are we sure?
Iron?
Aren't they related?
They are related.
Iron binds to one oxygen.
Huh?
Iron binds to one oxygen molecule.
What's hemi bind to?
The carbon dioxide.
During periods of maximal exertion, obviously your body temperature is going to rise. Your oxygen in your pH drop. Hemoglobin starts releasing in areas for more oxygen that's activated by those muscle fibers. Again, it's going to go back. We're going to be dealing with the calcium, our sodium, potassium, our electrolytes, and our readings for what those. You're going to go from anaerobic to aerobic respiration at that cellular level, and the need for oxygen is going to obviously increase. If hemoglobin does not release more oxygen, your PO2 will fall almost immediately. and exertion will either come to a halt or you'll pass out. That's like when you're running and you're like, I want to keep going, but I can't. That's your body's way of saying, if you don't, you're going to face plant on this concrete and you're going to halt in a second. Carbon dioxide transport is generated by aerobic metabolism in peripheral tissues. In the bloodstream, it dissolves into that plasma, binds to the hemoglobin within the red blood cells, and is converted to H2CO3. You'll see that again here shortly. H2CO3 is the molecular structure of carbonic acid. Why do you have a shitty expression on your face?
I know exactly why I have a shitty expression on my face.
I thought we established anything.
Plasma rapidly becomes saturated and accounts for about 7% of the carbon dioxide absorbed in the peripheral tissues. The other parts are on the hemoglobin, obviously. With hemoglobin binding, it binds to the globin protein portion of the hemoglobin. It forms carboaminohemoglobin. It does not interfere with oxygen binding at the heme units. But those hemoglobin account for about 23% of the carbon dioxide in the blood.
Sorry, I don't remember that one.
Huh?
I don't remember that formula off the rip.
You don't have to. I'm just writing down one portion of our pen. And we said this is called what? Okay, we'll get back to that in a minute. Carbon dioxide is converted to carbonic acid, and carbonic anhydrase enzymes in the red blood cells help that breakdown happen. Carbonic acid molecules dissociate almost immediately to form hydrogen and bicarb. Does anybody know what the formula for bicarb is? Bicarb is HCO3. Okay? But what did we lose here?
One of the
Hydrogen.
Right? So this So where do we deal with, when we're dealing with bicarb, are we dealing with the respiratory side of things or the metabolic side of things? Metabolic, good. So inversely, let's go with my pea bird here. When we're dealing with the respiratory side of things, right? What do we measure CO2 off of? Or end tidal off of? I should give you a fucking answer.
Carbon dioxide.
Okay? But what do we lose over here?
two hydrogens.
Oxygen,
And,
H2O,
And this is called what?
water. I thought you said H2O.
So you have this one thing in your body, carbonic acid, that is released through two systems, metabolic or respiratory. This is why I tell you, Jesus Christ, in my opinion, end tidal is the most underutilized vital sign that exists on the face of this earth. Because it can tell you not only what their breathing is doing, but what their body is doing metabolically. Has the ability to. Now, I'm not a super smart man, but I like trends and I like numbers, right? And I've come up with my own little thing that works for me. And just like they say in Anchorman, 80% of the time, it works all the time. So, then we can all break in this person's house. So, when we're dealing with, I forget the way that I wrote this. I'll hear it back, because I don't want to confuse you.
Do you want a picture?
Huh? You still have it?
Yeah.
Cool. I just don't remember what I put at the top to make it easier for.
I don't know if you'll have it.
Let me have this.
Yeah.
So, what did I put up here for you guys? What about this? So now when we're talking about end tidal, we typically think of it from respiratory purposes, right? That's what probably all of you think about it as right now. So there's this mnemonic that I use called Rome. Somebody just said, Who said that?
I did.
Have you heard this before?
Yes.
Okay. So, respiratory would stand for the R. What do we think the O stands for? Opposite. Okay? So if I have an increase, this would be normal situations. If I have an increased end tidal CO2, what should my respiratory rate be? Lower, right? Because I'm breathing less, I'm blowing off less, meaning I'm retaining more, right? But what is that? So what is our normal pH?
7.35 to 7.45.
Okay? Now, we're going to use this here. At that, my pendulum is flat. As long as I'm between that 7, you still have that on your thing? I usually do it on the other side, so I just want to make sure I get this right. So, in my office, there's a little black book. I'll just take it. Be right back. Take 5. I want to do this right first time, so I don't confuse it. Because the way I do it in my head is what I teach people that are. They don't work.
No. Yeah, they are the first one on them one day. They was so upset.
Who said they saw Rome before? You? What was the M in Rome again? There's metabolism? Metabolic.
Yeah, metabolic is equal. E's equal.
Yeah, I just didn't know. I had it shortened. I couldn't remember what it was.
I want to say this is the diagram I use, and it's very helpful. To do that, go around your pH, then it tells you which one will be. That's more, this is, that's just what it's, that mark. It just makes it easier.
Puffs coming out.
This shit is the shit that's fun for me. This should be way more entertaining than it was 2 weeks ago.
Honestly, I always enjoyed that.
Are you going to find out do one box of each, or you don't mean to do all the ones that aren't labeled?
I'd rather just do everything all at once, as far as narcs, that way we don't get into the issue that we had before where shit was done and wasn't done. Because I know there's 2 boxes of Versed. 4? What do we have so much?
Order 2 more boxes, but there were 2 full ones. And there's 2 fentanyl.
Definitely do both fentanyl. I know it's gonna be 50. It's gonna sound good. Just do all the fentanyl, do the morphine, do the Dilaudid, just do 2 boxes of Versed. If all the constants are the same, just do 2 boxes. If it's 2 of one and 2 of the other, then we need to do all 4.
Do we do ketamine or we do that one for a while?
Just go ahead and do the ketamine over there.
Like 75 bucks, lifetime. So, it just dumps everything down. Just simpler, yeah. Oh, I could probably just make a copy of it later.
Or you can scan them in and send them out through,
You should talk to me in your Snapchat.
I could do that too.
At least your house.
But I did. His one picture was that I worked with, she just graduated from high school. And this is all she used, and she has her stride. And also, this.
Everybody back? Okay. I've spent so much
This
time.
stuff is now.
Okay, back to this. So, if I see that So if my end tidal is up, right, my respiratory rate should be down. And with that, what should my pH be, up or down? Look at your pendulum here. Because pH is based off what? Let's start there. pH is based off what? That right there. Okay? So if my end tidal is up, what is my pH going to do? So if this side of the pendulum comes up, what's happening to this side of the pendulum? So my pH should be down, right?
Yes.
But inversely, if my end tidal is down, what's my respiratory rate going to do? Up, right? And if my end tidal starts to come down, what's happening to that side of the pendulum? It's going to go up. Now, we can control that through several means. We can sedate and paralyze and breathe for them. We can do BiPAP. We can do CPAP. We can coach them. Not everything has to be invasive. We don't always have to swing for the home run. Sometimes the ground ball will get us on base, right? So we don't always have to RSI and intubate and CPAP everybody. We start with coaching. We give some passive oxygenation. If we have to bag them, we bag them. If we CPAP them, we CPAP them. If we BiPAP them, we BiPAP them. If we intubate them, we intubate them, right? But on the other side of things, we can't always see, right? So, and that would be the metabolic side of things. Even with us having an iStat, we can't see everything going on in the body. We can only see a few select things. So, when I'm dealing with metabolic, right, and when we're talking in Rome, it is in response to this, right? It's in response to the end tidal versus respiratory rate. Because if my end tidal's up, my respirations are down, that's opposite. And if they're down, they're supposed to be up. But now with this, if I see I have a patient with an increased end tidal, let's say a 70, right? But I also see that their respiratory rate is 30, I can now deduce that I have a metabolic issue. Because does this match? No. Now with this, what is going to happen to my pH? My end tidal goes up, what's going to happen to my pH?
Down.
It's going to go down, right? And inversely, if I have a patient with an end tidal of 20 and a respiratory rate of 6, right? My end tidal comes down, what happens to my pH? It goes up. Now, I know what I need to do or not do to treat my patients, whether it be respiratory in nature or not. Because with this, and this is my 80% of the time it works all of the time things, is that, put this correctly, this is going to be cause versus compensation. Now, these two can inverse because obviously you can become septic or have metabolic issues without respiratory, right? But I know that even if they don't have any respiratory issues, right? Maybe let's just say this is sepsis, right? What is my body's initial defense mechanism going to be to offset that? To increase or decrease my respirations as needed. So my compensation mechanism for my metabolic side is going to be what? Respiratory, right? And inversely, if I'm having respiratory issues, is that only affecting my lungs? No, it's affecting the entire amount of carbonic acid that I have in my body that is going to break down into bicarb that is going to affect my pH. And I can do one of two things with that: control breathing or correct it, or give medications. Did you have a question, Jackie?
I was just gonna point out.
Oh, thanks. Yes, it is. So if I'm doing respiratory-based theory of this is my patient's issue, I'm going to expect that if I have an increased CO2, right, I'm going to have a what pH?
Lower pH.
Decreased pH, right? And inversely, if I have a decreased CO2, I can expect to have a what?
High pH.
Increased pH. However, if I have an increased, what did he just say? R91 is going together. Input. If I have a decreased CO3, right, I can have to expect to have a what pH?
What are you saying? 2 degrees?
This is probably one of the most important things that I can teach you and you can understand. Because now you have the ability, again, I'm not saying it works every time, but 80% of the time, it works all of the time. Sex Panther, right? You can use this on a majority of your patients. That you can take something as simple as an end tidal reading, know that their respiratory rate doesn't match their end tidal, and automatically start looking for those metabolic causes. Is it renal failure? Is it sepsis? Is it some type of infection? What is it? What can I do and what protocols do I have? Do I have antibiotics? Do I not? Can I give calcium? Can I give bicarb? Can I give D50? Are they in DKA and I need to do something to correct that? We now know that based off of this respiratory reading, I can see about 75 to 80% of what I can control in the body. And I can control it one of two ways. Hopefully, the easier way, through their breathing, right? Because it's very easy for us to control their breathing, or assisted breathing. Or, if my protocols allow, I can now give medications that are needed depending on their pH. Because we should be learning how calcium interacts with bicarb, and how sodium interacts with bicarb, and how magnesium is going to affect things and what's going to happen in my body. Just for the simple fact, what is magnesium, just on the grand scheme of things? What does it do to muscle?
Does it relax
It's a smooth muscle relaxer, right? So if I have muscle relaxation, right, what am I going to then inversely see? What is in my concentrations in my blood? Because I'm using less of it now. What do I need? What is the one thing that I need to move troponin off of muscle fibers to make that? Calcium, right? So if I give magnesium, right, I'm going to have an increase of what? Because there's less being utilized, right? And if I give an increase of calcium to cause muscle contractions, what am I also going to then see a decrease in my body? And we'll get more into this in pharmacology. I don't expect all of you to know this right now. But again, there's a third of you sitting in here going, makes sense. A third of you going, I kind of get it. A third of you going, I'm gonna find the nearest tree in the biggest rock. I get it. So just bear with me. Take a picture, write it down, save this video, whatever you need to do to go back and listen to it. But this is one of the most important things. I literally will use this on every patient that's not bullshit. Any patient that I'm actually doing treatment on, I will do this on. Unless I can say, hey, I can see your femur. Probably not as important at that point, right? Any medical patient, I will use this on. And some of it might be, I make it to step 1 and go, okay, it matches, and now I gotta control this, or not control this. Or I'll go in all the way through the algorithm and go, they could probably stand from bicarb bolus, they could probably stand from a certain drip, or whatever they might need to do. This is one thing that he just got out of the last class that I harped on every module in their class for them to understand. And they probably use it more than they realize now. Agree or disagree?
All day.
Yeah. This whole weekend was them utilizing that. So, again, While the respiratory system is just one thing, it affects everything in your body, or can affect other things in your body by doing certain things through it. That's perfect timing. If you look on that slide and then look back on the board, it's almost like they match. Except my positive and negative are backward. But other than that, that's pretty close. No, it wasn't. That was right. What did it? Okay. So that right there is your carbonic acid. Right there. This is your bicarb, and this is your N-title. Same thing that's back there. These reactions occur rapidly. They can be expelled through CO2. You can have free radical oxygen as needed, and those reactions are completely reversible. Again, that's why your body will try to compensate through the respiratory side of things, because it's so easily reversible to say, hey, if I increase my respiratory rate, it should decrease this, or if I decrease my respiratory rate, I should increase this. The problem is when your body can't compensate and it decreases its respiratory rate, but your N-title now continues to drop just because there's so many free radical hydrogen in there, that at that point you have reached decompensated shock because it can no longer control itself, maintain itself. Most carbonic acid immediately disassociates, and again, forms between your N-title or your bicarb in your body. It's going to go as needed in your body. Do we need bicarb to do it, or do I need to breathe some of this off? Because what is this part of the body? It's internal what? Buffer, exactly. Those reactions are going to shift from left to right, and by left to right it means based off of this. It'll go back and forth as needed in your body. Carbon dioxide is going to continue to rise and diffuse out through interstitial fluids in our lungs. Hydrogen and bicarb atoms are continuously being removed and supplemented as needed. The hydrogen is going to bind to the hemoglobin, prevents the release from red blood cells, and that would lower the plasma pH. Bicarbonate ions diffuse into that plasma. Each one of those bicarbonate ions are matched with a chloride ion, and that is known or referred to as the chloride shift. And that's why in septic patients, why it is important to give them specifically, at times, sodium chloride. It's not so much that it needs the chloride or dependent on the pH at that point, it needs the chloride portion to bind with those bicarbonates to reduce that. It's going to diffuse out of the plasma within the lungs. Your PCO2 should decline, and your O2 should increase. As PCO2 declines, carbon dioxide diffuses out of the red blood cells, hydrogen ions leave the red blood cells, and they are then converted to water and CO2 that we breathe off, and that is known, again, as N-title. That is how closely related your metabolic side and respiratory side interact, is that it's literally the same thing until it gets to the lungs, they break apart and that CO2 and are breathed out. That's why we can have such an accurate reading of what's going on not only the metabolic side, but the respiratory side as well. Control of respiration. With unbalanced rates, the cardiovascular and respiratory systems need adjustment, either changes in blood flow and oxygen delivery. That'll be under, obviously, local control of what is needed in that area, or changes in depth and rate of respiration, which are going to be controlled by your brain. Local control regulates the rate of oxygen at a specific area of tissue and regulates the efficiency of oxygen absorption in the lungs. With the rate of oxygen delivery, the peripheral tissues become more active. Your interstitial PO2 falls and your PCO2 rises. Why? Because those tissues need oxygen, right? And the byproduct of that oxygen is going to be acid that's going to break down and increase your CO2. Your increase in the partial pressure difference from the arriving blood is going to cause that shift. More oxygen is going to be delivered, and more carbon dioxide is going to be removed. Because as your muscles are being used, oxygen is going to go down, CO2 is going to go up until that oxygen gets there, and again, they're going to sit there and try to maintain equilibrium at those sites. When you have elevated PCO2 readings, it causes a relaxation of that smooth muscle and increases blood flow. So again, if I'm at the gym just doing leg day, right, I'm going to have way more blood flow to my legs than I am my upper body. Why? There's more demand, right? Regulating blood flow in the lungs, it improves the efficiency of the gas transport. Obviously, we need blood to transport that oxygen in and the carbon dioxide out. The blood in the alveolar capillaries is directed to lobules with the high PO2 because it needs to pick it up. The areas with those with the low CO2, those precapillary sphincters are going to constrict, allowing blood flow not to go there and to go to the areas of the higher concentration of oxygen to pick up. Bronchial smooth muscle are going to be sensitive to those CO2 levels. As PCO2 increases, they're going to dilate. Airflow is going to be directed into those lobules with the high CO2 because it's going to need that oxygen to get there for the gas exchange to happen. And areas with those PCO2, they're going to constrict because if it's lower, it needs less of a shift, right? So it's going to direct the oxygen to the areas of higher concentration because it needs that homeostatic exchange, and the areas with low, it's going to just require less exchange. When we're talking about when it becomes controlled by the brain, you have an involuntary respiratory centers, again, located in the medulla and the pons. They help regulate the respiratory muscles, and it is going to control the frequency and depth of your breathing. So rate and depth are going to be controlled. Involuntary respiratory centers, they're going to respond to sensory information. You are not going to have control over this. That's like when your body is going to say, I need to increase my rate to 28. You can't be like, slow down. Your body's going to go, no. Because if not, you're going to pass out because you're not going to have enough O2. Now, obviously, if you stop exerting yourself, it's going to lower because it's going to be less muscle use. That O2 is going to increase quicker because it's no longer being utilized. It was intaking for a minute at the rate at which it was using, and then the more that increase comes up in O2, the slower our breathing is then going to get based off the demands of your body. Your voluntary respiratory centers, reflex activity in the cerebral cortex. Respiratory centers have 3 pairs of nuclei located in the reticular formation of the pons and the medulla. You have rhythmicity centers that are located in the medulla, and they set the pace and rate for respiration. Your respiratory rate should be much like your cardiovascular rate, not at the speed, but at the rhythm of it. If you're breathing 3 times in 10 seconds and then 2 times in 30 seconds, that is not a normal rhythm, right? It should be methodical and carried out as the demands. Now, if the demands of your body change, that rhythm is going to change, but it should still be uniform over the course of what you're doing. If you don't have that rhythm, does anybody know what that's called? Ataxic breathing. Okay? That's when you have different rates that aren't associated with what's going on. And those are the patients that we here typically go if it's not a it's not a glucose issue or something we can control. We don't CPAP them, we don't BiPAP them because they're not breathing at a normal rate, and that's something that we need to RSI them to breathe at a normal rate for them, because ataxic breathing is not safe or healthy for that patient and will not be sustained long term. I'm not going over there. I won't test you on it. I won't test you on that. The respiratory in the center in the pons adjusts the rate and the depth. And that is in response to sensory stimuli, emotional states, or speech patterns. I mean, I guess you can know your DRG and respiratory center during quiet breathing. Can't say that one of those would be ruled out. Just know that your dorsal respiratory group is in control of your quiet. Maintains basic rhythm in absence of sensory or regulatory stimuli. So this is your passive or quiet breathing. While your ventral functions only during forced or modes of accessory muscle use on inhalation and exhalation. Factors that affect those respiratory centers or any metabolic or chemical activities in those neural tissues that it's going to pick up from your body. Anytime there's an increased respiratory rate, you should see an elevation in blood temperature or body temperature. This is why when you take MDMA or cocaine, both of those are stimulants that are going to obviously just inversely increase your respiratory rate, which is going to increase your body temperature by nature. Modifications, you can have information from your chemo or receptors. Information from receptors alters the pattern of respiration. That's why you'll see, during diabetic issues, you'll have that deep, drawn out breathing because it's trying to take in as much as it can and blow off as much as it can. That's picking up on the chemoreceptors of the body saying, hey, normal breathing is not going to help here because we're not going to blow off enough and we're going to become acidotic. Old Kushmals. Inflation reflex prevents overexpansions of lung during forced breathing. Obviously, you can't inhale forever, or your lungs will pop and then you'll inhale never. Stretch receptors, much like your bladder in your lungs, are going to say, hey, we have reached the point of maximum occupancy, stop breathing. Just like at some point, your body will prevent your bladder in most cases from overexpanding because you just start to pee yourself. Like if it reaches to a point that it says we are going to rupture if we don't excrete some of this, your lungs do the same thing. Sensory fibers in the lungs will reach that threshold, and they can reach respiratory rhythmic centers through the vagus nerve. So they're going to say, hey, at this point, stimulate this. It's going to reduce our reduce our need for this, depending on what's going on. That inflation reflex is mainly seen with your ventral respiratory group because that is what is used for your forced breathing, like we discussed earlier. Inflation is going to stop near max volume. And obviously it's a lot easier to hold a breath. Like if you take just a minimal breath, you can hold that in longer than if you take a huge deep breath because you're going to have that stimulation of saying, we are overstimulated, we need this out now. And then when you exhale, it's going to be a huge quick exhale because your lungs are like, don't like this at all. I want this out and I want it out now. Deflation reflex inhibits the expiratory center, stimulates the inspiratory center as the lungs collapse. The smaller the lung volume, the greater the inhibition of the expiratory center. So what that's saying is, hey, we have reached to where my lungs are comfortable being deflated. If we go any more, they're going to collapse. Stop breathing out or breathe in. It's kind of that negative feedback loop, right? Don't do this, do this. Do this, don't do this. Herring-Brar is the inflation and deflation reflexes. They're not involved with quiet breathing. And they're done during strenuous exercise. You'll have both, meaning it's taking in as much as it can and pushing out as much as it can. You have carotid and aortic baroreceptors. As the pressure falls, your respiratory rate is going to increase. Again, supply and demand. If I'm circulating less blood, I'm going to need more oxygen concentration in that blood since we're moving less. And as it rises, your respiratory rate is going to decrease because it says we're moving a bunch, so I can breathe less. At some point, that's going to be bad though. This results from respiratory center stimulation or inhibition, and you'll find those sensory fibers on the glossopharyngeal and vagus nerves.
We did really good today.
Yeah, you waited until almost noon.
I'm sorry.
You're good. Chemoreceptor reflexes respond to chemical changes in blood and CSF. Stimulation increases depth and rate. Your carotid and aortic are sensitive to pH, PCO2, and PO2 in the arterial blood, while your medulla is sensitive to pH and PCO2 in the cerebrospinal fluid. Your carbon dioxide levels are more powerful effect than your oxygen levels. That is how we breathe. So normal breathing says what? Does anybody know? The reason we breathe?
Too much CO.
I have too much CO2, so I need to breathe off, right? When we're dealing with the hypoxic drive, what happens then? Anybody know?
Based on oxygen concentration.
Based on oxygen concentration, correct. And that's why we have to be careful, people that rely on the hypoxic drive, because if we oversaturate them with oxygen, what does their body tell them to do? Stop breathing because I have enough. Correct. Slide. A fall in arterial PO2, oxygen and carbon dioxide receptors work together. Carbon dioxide generation increases when oxygen consumption increases. Again, the more that those tissues are going to absorb the oxygen, the more their arterial blood is going to become saturated with that CO2 because it wants to maintain that ship. Breakdown of oxygen and carbon dioxide receptor only occurs in unusual circumstances. Deep breathing before breath holding. PCO2 is reduced enough, rising levels are not enough to trigger the breathing. So that's why if you're going to take a deep breath, like blow a couple off, that way it takes longer for you to exhale that breath. So people that are like, I'm going to hold my breath underwater. If they just go, and they go under, they're not going to stay down as long as if we force a bunch out real quick and then take a deep breath. We have longer time for those CO2 values to build up. But at a certain point, those O2 levels will decline, causing unconsciousness. That's also bad, especially if you're underwater. It's also a dumb slide. CO2 receptors are sensitive pH. It's part of what your pH is compromised of. Elevated lactic acid levels, pH increases, respiratory activity, all of those are going to be based off your CO2 receptors. you have influence on respiration, specifically from the pons, direct control of your respiratory muscles. Like I stated earlier, singers have a lot better control over that than people who suck at singing. They have the ability to suppress or exaggerate certain sounds, like as much as like certain types, but like that screamo music, those people have some fucking insane control over those muscles, because that has the potential to cause harsh trauma to those, and they can control all that and exaggerate those muscles more than most. Why are you smirking up there? Did you listen to that weird music?
No.
Your limbic center, activation of centers controlled with rage, eating, and sexual arousal, and alter the depth and rate of respiration. Obviously, if I'm pissed, I'm going to be breathing deeper and faster. Also, if I'm sexually aroused, because I'm out of shape. If I'm eating, it's going to be less because I want more food than I do air. Changes at birth. Before birth, those pulmonary vessels are collapsed, rib cage is compromised, and the lungs and conducting pathways contain small amounts of fluid and no air. Why no air? Never been exposed to it. Can't have something that's not exposed to. There's a couple more slides and we'll go over just so we can check. At birth, the first breath, though powerful, through powerful contractions of the diaphragm and external intercostal muscles, force air to be inhaled in. That pushes all that fluid out. Sometimes they cough. That's why they get suctioned right at birth, because they're getting all that fluid that was initially in those passageways out. When they cry, it comes out. If they cough, it comes out. But once that fluid is pushed out of the way, it helps inflate that bronchial tree, as well as the initial inflation of those alveoli. But again, that's why O2 readings on newborns is so important, is to make sure that their entire respiratory system is in fact inflated and working, because you have no proof of concept prior to that. You have a drop in pressure in the lungs when it pulls air in, and it pulls blood into the pulmonary circuit. The candy is rough. At birth, exhalation does not empty the lungs. The rib cage does not return to fully compressed state. Those conducting passageways are kept open, that bronchial tree is kept open, and surfactant does not permit alveolar collapse.
I'm not gonna get another one.
Oh my God, that tastes like stagnant something. It's like pond water.
Is it expired too?
No.
I try to do a nice thing for you and you want to bitch about it.
If you would have had that in your mouth, you would have bitched about it too.
You put way more things in your mouth than I do.
And that was by far the worst.
Chest movement is restricted through arthritic changes, decreased flexibility, and age-related muscular weakness. Again, as people get older, muscles get weaker, bone structure becomes compromised. The older population has more or less inability to control their forced breathing, just because there's not as big of a supporting factor in muscles and lung tone. Limited pulmonary ventilation and vital capacity. This is why they can't do as much. Emphysema It's normal to some degree in the geriatric population. Their extent is going to vary with exposure to respiratory irritants. People that smoke, back in the day that when we had a bunch of coal mines and foundries, their exposure to all that dust, debris, those people had chronic COPD and chronic emphysema. That just was the environment that they were in. That's on page something. You can see how the respiratory system works with the other 10 systems in your body, if you're interested. Any questions, concerns, comments? 12:45. Where's